everyone. Good morning, and congratulations for making it back to our day 3 after a very action-filled and exciting day yesterday. I'm impressed to see so many of you here at 9 a.m. And I want to start by just saying a word of appreciation to our sponsors who helped make everything that you enjoyed, hopefully, and participated in yesterday possible. So thank you to Regeneron, our visionary sponsor, Ipsen, our leadership partner, Insight, our gathering supporter, and to Ashibio for their additional support. And I wanted to start our day off with one more jolt of excitement to hopefully help us all wake up. So if you have enjoyed this year and the family gathering and all that you've experienced, hopefully you'll take this opportunity to mark your calendar for 2027. We will be meeting in Philadelphia in June, so this is a different timing than we've had in the past, but we know that for a lot of people, especially our younger families, a summer date is a little bit more convenient for them. So we are shifting to a new schedule in 2027, and I also wanted to say that if you've enjoyed the programming so far, it's because so many community members have been a part of the planning to share their expertise or their ideas, and so just don't hesitate to reach out to me after the event if you want to be involved in the planning for 2027. And I know that you all are aware that one of the priorities we have for our general sessions here at the Family Gathering is to share the most recent updates with all of you. And I could not be more excited to start today's session off with a brand new publication that just came out in May of 2025, so this year. And up first is Dr. Kaplan, who is going to be speaking to us about today's topic, which is thoracic deformity and FOP. So please join me in welcoming Dr. Kaplan, the Isaac and Rose Nassau Professor of Orthopedic Molecular Medicine and the Director of the Center of Research in FOP and Related Disorders, to the stage.
Well, good morning, everybody, and thank you, Hope, and thank you also to all the sponsors for this magnificent event. We certainly have come a long way in the last 25, 30 years. This morning, Dr. Pignolo and Dr. Sponsler and I would like to shine a light on something that we haven't talked about very much, and it's very, very important for everybody with FOP, and that's the thoracic deformities in FOP, the chest wall, and the pulmonary complications. There's a adage in the theater that if a gun, a pistol, appears in Act 1 of a play, it's going to be used by Act 4. And we're going to see that this morning. And one of the challenges that we have in therapeutics for all the pharmaceutical companies here is for the long term. How can we prevent some of the long-term complications, the short-term and the long-term complications of FOP? So the title of this morning's talk is FOP, the Great Wall. And these are my disclosures, and I have no financial conflicts of interest at all. A wall, as it's defined, is a structure that encloses a space and provides security. That's what a wall is. And the earliest known organism with a great wall, a thorax, is a trilobite. This is a picture of a trilobite from 531 million years ago, 500 million years ago, from Mount Burgess in British Columbia in Canada. But in humans, the Great Wall is the chest, and the chest is dramatically affected by FOP. So how does FOP affect the chest wall? Some ways you know, and some ways may be surprising to you. And why do we care? We care because what's inside the chest wall? The heart and the lungs. Basically. There are other things as well, the esophagus, the great vessels, but focus on the heart and the lungs. They're inside the Great Wall. They're not affected by FOP directly, but indirectly they are affected greatly. And so the FOP mutation affects mobility of the chest wall by causing thoracic deformity, TD. And all of this is, as Hope said, it's in a paper that is published and should be on the IFOPA website and on the ICC website, and perhaps it's here that Dr. Pignolo and Spinal and I published in May in the Journal of Bone and Joint Surgery Reviews. It's about thoracic deformity and FOP. And so there's a spoiler alert, a warning. Thoracic deformity and FOP comes in 3 different varieties or 3 different flavors. Developmental arthropathy. What is arthropathy? Arth is Greek for joint, as Aris knows, and pathy is abnormal, so developmental arthropathy is development of abnormal joints. We all know the toe, but we're going to talk about other joints that are abnormal as well in the thoracic spine. Heterotopic ossification, which we all know, which usually begins in childhood, and also a problem that may not be apparent to you, but there is growth plate dysregulation. Growth plates are in children. That's how the bones grow, and there's dysregulation. We see this in the mice, and we see it to a variable extent in humans as well. So let's examine how the FOP mutation causes thoracic deformity. We all know what the FOP mutation is. It's ACVR1, and the common mutation that we see in 95 to 97% of individuals around the world is the R206H mutation, where histidine is substituted for arginine in one place in the receptor, and it causes lifelong problems that we know. But basically, we can divide this. This is not a basic science talk, but we can basically divide this into 2 realms. One is the leaky faucet that we see, and one is the inflammation and activin A dependent exploding faucet that we see. And the leaky faucet that sends the signals to the cells leads to the great toe malformation. It also leads to other malformations, and the exploding faucet leads to the heterotopic ossification. It's sort of a simplistic way of looking at it. But in addition to the embryonic malformations of the toes, we see malformations of many, many other joints around the body, in the cervical and thoracic spine, especially in other areas of the appendicular skeleton as well. And then, of course, the exploding faucet, which we'll hear more about later this morning from the folks from Regeneron. But in order to understand the skeletal consequences of FOP, we have to understand joint formation in addition to bone formation. And one of the students that worked with Eileen Shore, my colleague Eileen Shore in the laboratory, was Will Towler. And he looked at the CAT scans of the CT scans in the natural history study, and he found many abnormalities. But he also did a study in mice. And basically, this slide summarizes some of the findings. So normally, we have ACVR1 signaling, and it signals, regulates the canonical BMP, bone morphogenetic protein pathway, that affects growth plate and cartilage ossification, and a very balanced formation, very balanced regulation of joint formation. So how does FOP change this? Well, FOP dramatically increases the signaling through the bone morphogenetic protein pathway, but it also inhibits the formation of the joints. And an easy way of looking at this is too much of a joint-making signal, an overactive bone-making signal in FOP leads to an underactive joint-making signal. And you may or may not know this, and I didn't know this until I went to medical school, but let's take a look at the upper limb. Basically, the whole body forms this way, but the upper limb, and we're talking about the earliest formation of the upper limb in the first 12 weeks of embryogenesis, when we're still in embryo, less than 1 centimeter in size. The upper limb forms as one piece of cartilage, and where the prospective joints form, like the shoulder and the elbow and the wrist, signals go out in those locations to say, stop making bone here, do not make bone here, and do not make bone here. The same is true in the spine. And if there's too active of a bone-making signal, like we see in FOP, there's too little of a joint-making signal. And this is obvious in the malformation of the toes, but it's obvious also in the malformation of other joints that Will Teller showed by looking at CT scans from the natural history study. So the malformed joints lead to early degenerative and developmental joint disease, and they lead to joint fusion, in other words, ankylosis of the joint, not from heterotopic bone, but because the cartilage doesn't want to remain cartilage and the joints fuse. And in FOP, approximately 100 joints are affected in the chest wall. This may come as a surprise to many of you. And many of those joints are the costovertebral joints. What are the costovertebral joints? Costo refers to ribs, and vertebra refers to spine. And 72 of those joints are where the ribs join the spine. Now, when we take a deep breath, we breathe in, and it looks like the chest wall expands in the front. It does. But all the movement occurs in the back, because that's where the joints are. And there's 12 ribs on each side. Each rib has 3 joints. It's anchored in the spine at 3 joints, or anchored in the spine at 3 joints, at the vertebra above, at the vertebra below, and at the transverse process. And here you see the ligaments around those joints. You can see each rib has the vertebra above, the vertebra below, and the transverse process at that level. And inside these ligaments are joints. And some of those joints are affected. Those joints can be affected by FOP. And here we see on a view the front of the vertebra where the spinal cord goes down, and the back of the vertebra, and there's the rib coming in, and it's anchored in the vertebra at three different places. And those are 3 joints. And if those joints are malformed and they don't work and they fuse early, you don't have movement there. You can't expand your chest. And so the volume of the chest is less. And what's inside the chest? The heart and the lungs. In addition, there are intervertebral joints, which we call the spinal facet joints. And we have 24 of those joints, and they are where one thoracic vertebra joins the next thoracic vertebra. And we see that, we see that on this slide. We can see the facet joints above and below, and these are where the ribs join the spine. So there's, and 2 sides. So and we have 12 thoracic vertebrae, and each vertebra has 8 joints. So 6 costovertebral joints and 2 intervertebral joints, 8 times 12, 96, almost 100 joints in the spine, in the thoracic spine, can be and often are affected by FOP and give little volume. This came to light when, early on, when I was seeing children, and I would ask them to take a deep breath. And long before they formed heterotopic ossification, or early on in heterotopic ossification in the back, and they couldn't take a deep breath. Or if they took a deep breath, the chest wall didn't expand. And I wondered why. And now we know why, because some of those joints are not formed properly. And that occurs in embryogenesis at the time the child is, so at the time the child is already born, those joints are malformed, and they may be there, but they often go on to fusion very early within the first several years of life. And we can see this, so This is a side view of the vertebra, and you can see where the one vertebra meets the other. There are the intervertebral joints. So each vertebra, each level has 2 joints, 8 and 6, the ribs on each side, 3 joints on each side, and so there are 72 plus 24 equals 96, almost 100 joints. And we can see here on this CAT scan, on this view, that there's severe degenerative arthritis in multiple joints where the rib joins the spine here. And you can see that there's maybe a joint there, but the joint is locked there and there, and so there's no this joint doesn't expand, and obviously, if this occurs at multiple levels, the chest wall doesn't expand. And so the costovertebral joints are essential, are absolutely essential for chest wall expansion. And costovertebral joint fusion leads to reduced chest wall expansion and is evident, as I said, in early childhood. And we can see this here on a specimen of bone, of skeleton, at the Mutter Museum in Philadelphia, one of the skeletons that's often been displayed. And we can see here where the ribs are fused and the intervertebral joints are fused as well. So you can imagine now that the chest wall might not expand in this individual and is vulnerable in just about everybody with FOP. So one of the first things that can occur in the chest wall is developmental arthropathy involving the costovertebral joints and the intervertebral facet joints. And basically another way of saying this in plain, simple English is the joints don't form right in FOP in the spine as well as the great toe. And where do they not form properly? The hinges where the ribs join the vertebra, and the hinges where one vertebra joins another vertebra. The second thing that can occur in FOP that gives thoracic deformity in FOP is flare-ups of the back. And here you can see, here you can see 3 children who have FOP, and this is all familiar to you. The flare-ups that occur, the swelling that occurs that can leave behind pieces of bone. And here we see in an individual that a second skeleton is already forming, and we can see that there and there. So in addition to the joints malformed, we can see that the joint is further fused, further limited by this bridging heterotopic ossification. And the bridging heterotopic ossification in FOP spans vast anatomic planes. So it goes from the neck all the way down to the pelvis. And even in this view, you can see that the abdominal wall is affected, and there's a piece of bone here. This rarely occurs, but it can occur. We can get ossification in the abdominal wall. Sometimes we see abdominal wall bridging, but the flare-ups stop at the cartilage level rather than the bone level. So they don't necessarily have to stop at the bone level. They can stop at the fibrous tissue level as well, or they can totally disappear. So episodic flare-ups are the second reason of thoracic deformity. The chest wall muscles can be involved, the intercostal muscles, those are the muscles between the ribs, the abdominal wall muscles, and the fascia, which is the covering over multiple muscle groups and over the muscles, and the aponeurosis, which is covering over multiple muscle groups in the back. People often ask me why you get swelling in the back, but with a flare-up, but you don't get swelling in the limbs. I don't think that's I don't think there's any difference biologically. I think it's a difference in the fascial planes, and obviously, you don't get the fascia is very tight in the limbs, and you don't get expansion, and you get hypoxia very quickly, and dramatic amplification of heterotopic ossification. The third reason we see a chest wall deformity is because the growth plates are abnormal in FOP mice in people. And growth plate dysregulation can occur in the ribs. The ribs have growth plates. The sternum has growth plates, and we see osteochondromas, fancy word for osteo is bone, chondro is cartilage, almost means a lump or bump. So they're cartilage bone lumps, and they often occur in the near the growth plates, and give us actually one of the clues to the gene that causes FOP. And so this is a picture of three chest walls, three children with FOP and who have narrow chest walls, and you can see very narrow chest walls due to abnormalities in the growth plates. So thoracic deformity in FOP, as you can see, I've given you some examples, comes from developmental arthropathy. The joints don't form properly, not just in the great toe, but also in the thoracic spine, obviously heterotopic ossification, and growth plate dysregulation in the bones that, and several of the skeletal elements that form the chest wall. But that's only part of the story, so what's the rest? We talked about developmental arthropathy and the causes. We talked about episodic flare-ups and the structures it can affect, and we talked about growth plate regulation and dysregulation and the structures it can affect. But this can occur either symmetrically or asymmetrically. Symmetrically or asymmetrically. Any of these three processes alone or in combination. But then there's growth. I'm not talking about flare-ups, but growth, normal growth. And if there's symmetry, then with growth, you're not going to get curvature, you're going to get no scoliosis, but with growth and asymmetry, you may get severe scoliosis. So if any of these processes occur asymmetrically, you may get, with growth, you may get severe growth curvature. So this is a formula for disaster. Asymmetry in growth leads to severe scoliosis independently of flare-ups. So people often ask me, how can the scoliosis get worse and I haven't had any flare-ups? Well, if you have asymmetry and you have growth, that's a formula for severe deformity. And here you can see within 1 year where there's asymmetry and scoliosis. Oops, sorry. Scoliosis has occurred in there within a year. You can see the curvature in the spine. So when does this occur? When does growth occur? Growth, as we see in the, as we can see here, with growth curves, this has nothing to do with FOP, but in children who don't have FOP, growth normally occurs between 10, growth spurt normally occurs between 10 and 15 years of age, and that's around the time of puberty. And you can see here a change in the slope of the progression of scoliosis. If scoliosis does occur, it occurs more rapidly during that time frame. So we can often see an advancement of scoliosis if there's asymmetry of the chest wall, especially during this time. And here we see an individual who has FOP and severe scoliosis due to asymmetry of heterotopic ossification and perhaps fusion also of the chest wall, which limits expansion. And on this view, in addition to the view I showed you, we have a curvature also in the back of the spine, which is thoracic lordosis, as you see on the left, or thoracic kyphosis on the right, which can occur with growth. So why do we care about these things? Again, we care about them because of what's inside the chest wall, the heart and the lungs. And thoracic deformity, or TD, leads to TIS, which is thoracic insufficiency syndrome. TIS, thoracic insufficiency syndrome. And that's the inability of the lungs to fully exchange expand and exchange oxygen and carbon dioxide, the main function of the lungs. We think of the lungs as a big bag of air. They're not a big bag of air. They're multiple little alveoli, little like the packing crate material, but they're more than that, obviously, and they're very important. The lungs are very important in exchanging carbon dioxide and oxygen. carbon dioxide that builds up from metabolism and oxygen that we breathe. So all individuals with FOP have a restrictive pattern on their pulmonary function test. And here I've just indicated a very simple pulmonary function test. On the x-axis, we have volume. On the y-axis, we have flow. And there's not a lot wrong with flow with most individuals with FOP. There's some abnormalities there. But the main problem is the volume of the chest. The chest wall is decreased, and we can see why, these three major reasons. So everyone with FOP has thoracic deformity, but some with FOP have more severe thoracic deformity. And everyone with FOP is at risk for thoracic insufficiency syndrome because of the things I've mentioned. And prevention is the key. And the good news is that although thoracic deformity and thoracic insufficiency exists in all individuals who have FOP, it is not severe in most and can be managed conservatively. So what tissues compromise the chest wall in children? Well, here you have a list. It's a sort of a supermarket list of the things that the tissues that comprise the chest wall: the ribs and the rib cartilage, the growth plates, the vertebra, the scapula, the sternum, the intercostal muscles, the paravertebral muscles, the back muscles, the fascia, and the joints, which I've discussed extensively. They're all affected. They all can be affected, and they often all are affected by FOP. But there's one thing on this list that's not affected by FOP, and that's the diaphragm. It's one of the three skeletal muscle groups: the extraocular muscles, the intrinsic muscles of the tongue, and the diaphragm, which are not affected by FOP. And it's very, very important. What is the diaphragm? It's a big, ugly muscle that separates the chest from the abdomen. We all have it, and it's probably the most important muscle in our body because it's the most important muscle for breathing. It separates the chest from the abdomen, and this is a picture of a diagram of the diaphragm. It's a picture of the diaphragm. It's a big, ugly muscle, probably the most important muscle that we have in our body, and it's very, very important. It expands the chest, the lungs, and it helps deflate the lungs. So it's very important that we keep that healthy in FOP because it's not involved. So what does that mean for me, someone who has FOP, the individual who has FOP? It means that prevention is the key. We have to focus right now on the things that we can prevent. We can prevent, yet we cannot prevent the developmental arthropathy that occurs in embryogenesis that leads to the degenerative arthritis of these joints in the chest wall that limits their expansion. And we cannot yet, hopefully soon, very soon, limit some of the heterotopic ossification from some of the wonderful clinical trials that are going on now throughout the world. But everybody can do this. We can use respiratory vaccines to prevent lung damage. When you cut yourself, it heals with scar tissue. Same is true with the lung. When you have an infection and you treat it with antibiotics and the pneumonia is healed and goes away, what's left behind? Scar tissue. Scar tissue doesn't exchange carbon dioxide and oxygen. So preventing pneumonias, preventing chest infections is very, very important to preserve what we can with FOP. And we're talking about flu immunizations, pneumonia immunizations, perhaps in adults, COVID immunizations, and certainly RSV immunizations as well, subcutaneously. In adults, I know Ed's in the audience. I don't think the COVID vaccine can be given subcutaneously. It happens to be given intramuscularly. Personally, I believe that we don't need to immunize children, but that's up for discussion. But for adults who already have heterotopic ossification, it might be important to prevent that. But certainly flu, pneumonia, and RSV. It's important to use incentive spirometry. What's that? Those are the blow bottles that inflate the chest. Why? Because they exercise the diaphragm. I tell patients that that's like going to the gym for the diaphragm. Who uses incentive spirometry? Astronauts use it. Ballerinas use it. Deep sea divers use it. opera singers use it, and probably FOP patients should use it. Everybody should use that. And for children, it doesn't mean you need to use a blow bottle. You can do swimming. You can use a blowing instrument. You can blow bubbles for, as a child. But as an adult, if you're sitting by the television or a computer, you can use the incentive spirometer to take a deep breath and blow it out. You can't expand your chest wall because those joints don't work, but you can exercise your diaphragm, and your diaphragm will keep your lungs healthy. It's very important by the end of the second decade that everybody has a pulmonary consult, because the pulmonologist can look at these pulmonary function tests, and they can be another voice to use incentive spirometry. And Dr. Pignolo is going to talk about that as well. He's going to talk about all of the modalities that help protect the chest wall. So these are things that everybody can do. They can do respiratory vaccines. They can use incentive spirometry, however we define it, to exercise that diaphragm to keep the lungs healthy and keep the exchange of oxygen and carbon dioxide well, and keep those pulmonary pressures down, as Dr. Pignolo will talk about, and also a pulmonary consult that later in life we might want to do an echocardiogram. Again, Dr. Pignolo will talk about that. So these are the three things I've talked about, and Dr. Pignolo will go through this chart and talk more about it. Now, in the past, for the past 30 years, we've said no surgery for FOP. And we published a paper in 1994 that talked about spinal deformity in patients who have FOP. And by the techniques used then, we suggested that surgery not be done for scoliosis. And that's not been done. But over the course of years, the technology has changed, as Dr. Sponsiller will talk about, and our knowledge of FOP has changed, and our wisdom of FOP has changed. And I don't want to steal the thunder of the talk, but I'm just giving you some rumbles of a storm that's coming, a beautiful storm that Dr. Sponsiller is going to talk about in this symposium later on this morning, about rapidly progressive scoliosis and FOP, a small case series that has been submitted for publication to one of the Journal of Bone and Joint Surgery case reports. And as he'll tell you, surgical intervention can reduce developing spinal deformity and declining pulmonary function in adolescents. And while surgical correction may provide improved quality of life, it also carries very, very substantial risks, including new heterotopic ossification, which hopefully we'll be able to prevent on the horizon. We're not there yet, but hopefully we will. And perioperative complications, and physicians who treat spinal deformities in patients who have FOP should consult with a member of the International Clinical Council on FOP and Dr. Sponsiller about this. And this is not about the techniques of the surgery, but what have we learned about FOP in the past 30 years? We've learned that there can be rapid progression with asymmetry of these chest wall deformities that can occur. And you can get a rapid progression in adolescence around 10 to 15 years of age. During this time, there's also pulmonary function deterioration and deterioration in what one can do. It's interesting that as I said before, that although this scoliosis and the chest wall deformity may progress, there's often no flare-ups during this time period, or there may not be flare-ups during this time period. And so patients say, how come my spinal deformity is progressing, but I'm not having any more flare-ups? I'm not saying everybody, but some individuals. And so if there's rapid progression, if someone is 10 to 15 years during this time period, if there's pulmonary function deterioration, if the FOP has been quiescent, if the patients and the families are fully aware of the risk, and if there's an experienced team, we may, with our fingers crossed, consider surgery, and Dr. Sponsiller is going to talk more about that. And 3 of those individuals are in this room as we speak. I'm not please do not go away from this thinking that everybody should get surgery. You should not. This is not experimental, but it's investigational now. And perhaps over the course of time, over the next 5 or 10 years, we'll be able to consider this, not do this, but consider this on an individual basis if we have medications that can prevent some of the chest wall deformity. So when does this chest wall deformity occur? It occurs in childhood, and I've always said, I think everybody in the audience that knows me, I've always said that the spotlight for FOP is on childhood. Certainly, if we have medications that can prevent heterotopic ossification, we will consider removing in certain areas bone and liberating joints if it's safe in individuals. But the key is not to have this heterotopic ossification occur in the first place. And so the spotlight of FOP is on childhood. And this is an article that was written in the New York Times by Mike Mason. It was in the several weeks after the gene discovery. You've seen this before. And he said, finally, it has a sense of exasperation. Finally, with genetic discovery and the wonderful discoveries that have come after that you all know about, finally, with genetic discovery, hope, and that's a key word, hope, for escape from a prison of bone. And so the long-term goals of the FOP clinical trials are to prevent heterotopic ossification, and clearly that's one of the 3 main pillars of the chest wall deformity. But also, I've been thinking, is it possible, and we won't know this from any clinical trials that are ongoing right now, because clinical trials last for 1 or 2 years, we'll have to expand this, and this will be in the long-term studies, a long-term follow-up of drugs that are eventually approved 5, 10, 15 years. Do these drugs, if they're given early enough, will they prevent the joint degeneration that we see in the thoracic spine that also limits the chest wall expansion? Or is this a fait accompli that occurs during early embryogenesis? So this pistol that appears in Act 1, is it going to go off by Act 4, or do we take the bullet out? And we'll only know that with long-term treatment of FOP, and we'll see from natural history studies, is there less joint degeneration in some of those vulnerable joints where the pattern is set up in early embryogenesis. And as June Osborne from the University of Michigan said in a non-FOP context, in an editorial in the New England Journal for another, again, not non-FOP context, she said many years ago, and this is so important, when prevention is done absolutely right, absolutely nothing happens. And so this is a diagram of the pathway. You've seen many different diagrams of the pathways of FOP and different ways we may be able to intervene to stop both the heterotopic ossification and the joint degeneration, perhaps, that we see in FOP. But in the meanwhile, stop. Pay attention. We've paid attention a lot to the heterotopic ossification that occurs in the arms and limbs and other areas of the body. But think about the chest wall. Think about the chest wall. Think about the things that decrease the mobility of the chest wall. Think about things that decrease the volume of the chest wall, the developmental arthropathy, the heterotopic ossification, and the growth plate deformities. And think of the structures that are not affected by FOP, mainly the diaphragm, keeping those lungs healthy, doing what we can do. And again, incentive spirometry, pulmonary vaccines to prevent pulmonary infections, and a pulmonary consultation by the end of the second decade, certainly by the end of the second decade. So everyone with FOP needs to pay attention to the chest wall, and this is the great wall, the chest, and thank you for your time. And now you'll hear some very good comments about how to address respiratory health from Dr. Pignolo, and then Dr. Sponseller from Johns Hopkins we'll talk about the the surgery in scoliosis that was done, that I mentioned. Thank you very much.
Thank you, Dr. Kaplan. And as he mentioned, we do have a few copies of the publication out in the lobby. So if that's something you'd like to read more about, please do feel free to go out and grab one of those. But up next, we do have Dr. Robert Pignolo. He is the Robert and Arlene Coggard Professor at Mayo Clinic, and he's here to talk about thoracic insufficiency evaluation and management.
Good morning, everyone. So I'm going to talk about the evaluation and the non-surgical management of thoracic insufficiency. And let me start by just taking 2 minutes and putting this into context based on what Fred beautifully outlined in his talk. So the risk factors for thoracic dysfunction that leads to this insufficiency syndrome are basically the malformations and the fusions of the joints in the chest wall, especially the costovertebral abnormalities, the burden of heterotopic ossification, the abnormalities in the growth plates, and finally, the asymmetries that can evolve, especially scoliosis. The other important point, again, to put into context early, is that restrictive lung disease, that is the inability to expand the chest and eventually undergo adequate air exchange, is very, very common. Most patients are affected by age 15. Many are affected earlier in life. And this restrictive lung disease eventually causes cardiopulmonary complications, which is a primary cause of death in FOP. So we should take this very seriously. Okay, so my talk is divided into 2 parts. First, evaluation, and then medical treatment. And so what I'm going to do for both parts is I'm going to go through the process step by step of how thoracic deformity leads to insufficiency and the cardiopulmonary complications. And then, so I'll list that step by step on one side, and then I'll suggest what the diagnostic evaluations should be. So, for example, on the right side, we'll list the steps. On the left side, we'll list the possible diagnostic evaluations. So for thoracic, so we can detect thoracic deformity by physical examination, by chest X-ray, by specific radiographs looking at scoliosis, by thoracic CT scans, and here, of course, we see the sheer burden of heterotopic ossification in the chest wall. And so thoracic, oops, sorry about that. Let's see how I go back. Oh. Can you move the slide back 2? One more? Okay, great, thank you. All right. So thoracic deformity can lead to thoracic insufficiency syndrome. We can try to better detect that through physical examination. We can detect diaphragmatic breathing. We can do things like pulmonary function tests, sleep studies. There could be early evidence for thoracic insufficiency on EKGs. We can consider early pulmonary consultation. We can consider early or baseline echocardiogram. And this is a tracing from pulmonary function tests similar to what Fred showed. And here in the red is the restricted pattern. And again, restrictive lung disease really affects lung volumes. And so on the graph on the left, you can see that the restricted pattern shows lower lung volume. And if you look at it as a flow loop, it has a smaller flow loop. Okay, so in the presence of thoracic insufficiency, we have decreased vital capacity, and that's can be detected by pulmonary function testing. We have chronic hypercapnia, which means we start to retain carbon dioxide, and then eventually we can have problems with oxygenation. And these consequences can lead to things like increased risk of pneumonia and lung scarring. And again, we can utilize some of the same types of diagnostic evaluations. I've added here pulse oximetry, which is a measure of oxygenation, and then either a baseline echocardiogram, or if suspicion is high enough, other studies. And again, if suspicion is high enough, we can consider cardiology or pulmonary evaluation. So in the presence of these changes, what happens is the lungs have become increasingly more resistant, and something called pulmonary hypertension develops, and if left untreated, it can affect the right side of the heart. And so we know that some of the early symptoms include this shortness of breath on exertion and fatigue, but these are sort of vague symptoms, and so really we need a high index of suspicion of moderate or severe restrictive lung disease over a long period of time to really question what's going on. And you'll notice here that I've listed some of the same types of diagnostic evaluations, and that's on purpose. So we don't know when any of the consequences of thoracic insufficiency is going to be diagnosed, so we should always have a high index of suspicion. And if we do detect it early, we may need to repeat some of these same diagnostics in order to monitor them closely. So, as I mentioned, eventually, in the presence of this resistance in the lung, we have what we call pulmonary hypertension, which can eventually affect the right side of the heart. Now, this phenomenon of pulmonary hypertension is usually detected by something we call cardiac catheterization. But in FOP, because we really know the reason for the pulmonary hypertension, that is this restrictive lung disease, we don't really need to do an invasive procedure like that. And instead, we can do an echocardiogram. And on an echocardiogram, we can get an estimate of pulmonary arterial systolic pressure. And it's usually greater than 25 millimeters of mercury in pulmonary hypertension. Okay, so again, if the right side of the heart is going to be under strain. What does a muscle do when it's under strain? It tries to get bigger to compensate, so it hypertrophies. So the right side of the heart gets bigger. Eventually, you have right-sided heart failure, and over time, right-sided heart failure leads to left-sided heart failure. So when this is happening, what are some of the signs and symptoms that we can see? Well, we can read through the list, but again, if there's one or two of these signs or symptoms, in and of itself, since they're nonspecific, that may not mean much, but together, or if you have multiple of these symptoms, again, FOP, think of restrictive lung disease, you have to have a high index of suspicion to pursue some of these diagnostic studies. Okay, and again, in later stage disease, we need to involve cardiology and pulmonology, but not just at the end. This is sort of a mandatory thing. We need to involve pulmonology as soon as there is a suspicion, and once we have preliminary evidence that there's restrictive lung disease, and with the understanding that restrictive lung disease can also affect the heart. Okay, so let's switch gears here and talk a little bit about management. So I went through the different steps of how thoracic deformity can lead to thoracic insufficiency, ultimately affecting the lungs and then the heart. So what can we do about this? Well, now what I'm going to do is I'm going to take the same sequence of events, and instead of telling you about the possible diagnostic techniques, I'm going to tell you about what some of the therapeutic considerations should be. So Fred mentioned that at any time, and especially early after diagnosis of FOP, we should consider things that will strengthen the diaphragm and expand the chest. So we call that incentive spirometry. There is going to be a window of opportunity, if you will, where an evaluation for scoliosis surgery might be important for some individuals, and I'm not going to say anything else about that because that will be the subject of our next talk. So, again, thoracic deformity leads to thoracic insufficiency. What are some of the things that we can proactively do? We mentioned incentive spirometry, but as I'm outlining here in bold, it doesn't just have to be incentive spirometry. It could be something a little bit more interesting, like singing or deep breathing or other activities which keeps the lungs expanded. Fred mentioned getting adequate immunizations, especially against respiratory microorganisms that cause influenza and pneumococcus. So these are what I would call low-hanging fruit. There's no reason why all of the following shouldn't be done. Okay, so thoracic insufficiency syndrome leads to decreased vital capacity and this retention of carbon dioxide and often difficulty with oxygenation. One of the interventions that should be done under the care of a pulmonologist might be non-invasive ventilation. Some of you are familiar with BiPAP and CPAP and VPAP, but basically what these external devices do is it helps with breathing, it helps with hypoventilation, especially overnight. And I just wanted to make the point that it's not a good idea for this to happen, this device to be used with monitored oxygen. And the point here is that carbon dioxide and retention of carbon dioxide is the device that the body uses to drive respiratory effort. And so if we suddenly correct oxygen, that can affect that mechanism and actually decrease respiratory drive. So again, if these non-invasive ventilation devices are used, they have to be done under the care of a pulmonologist. And if oxygen is used, then there needs to be some sort of way to monitor that. So, as I mentioned when I was talking about diagnoses, the lungs are affected. It results in pulmonary hypertension, and the goal usually of treating pulmonary hypertension is to figure out what the underlying cause of the pulmonary hypertension is. In FOP, we know what that is. It's the restrictive lung disease. But we can't take away the heterotopic ossification. We can't easily do that. So it's really prevention. And if in this schema, a pulmonologist is not involved in the care, it definitely should be. So I think I heard Fred mention at least twice, there should be a mandatory evaluation by a pulmonologist at least by the end of the second decade of life. But I mentioned earlier that by the age of 15, most people have restricted lung disease. So it could be earlier than that, but certainly sometime during the second decade of life. And then, although we only know about this anecdotally, some patients have used a class of drugs called phosphodiesterase 5 inhibitors for the treatment of pulmonary hypertension. And again, this I think should be done under the monitoring of a pulmonologist. We don't know because we only have anecdotal reports. We don't know how effective this is or how effective it might be. So I think this is something worth looking at. Again, we're talking about ways to prevent the next step in the pathway that ultimately leads to these cardiopulmonary consequences. So in end-stage disease, again, I want to reiterate that if cardiology and pulmonology has not already been involved, I think the care has to be initiated, especially when there's these end-stage consequences that are being identified. And again, I am highlighting the fact that unmonitored oxygen shouldn't be used or used under the supervision of a pulmonologist. So patients with FOP have procedures. They're often hospitalized for those procedures, or perhaps they're hospitalized for other reasons. I think in the setting of thoracic insufficiency and perhaps some of the later consequences, some of the considerations for care is how to effectively clear secretions, and I've made some suggestions for that here: adequate hydration, guaifenesin, bronchodilators, mucolytics if needed. And then also in the setting of procedures or hospitalizations, it's also not uncommon for the the requirement that someone's going to need anesthesia. That has to be done by nasal fiber optic intubation of the trachea. And then, again, I'm talking about in the setting of these later consequences of thoracic insufficiency, decisions like planning for extubation, like the removal of the anesthesia, you need to plan for how that should be done and weighing that against the possibility of having a tracheostomy. And that's because just extubating someone who has later stage thoracic insufficiency may not be good enough in terms of the real possibility of respiratory failure. And so this type of decision making should be done in consultation with FOP experts and pulmonologists, because the likelihood of extubating someone and them being able to breathe on their own is more tenuous in someone with thoracic insufficiency than in someone without thoracic insufficiency. And then before I end, I just want to say that the take-home messages are early diagnosis and early treatment, which in this case is really prevention and close monitoring. So I will end there, and thank you for your attention.
Up next, we have Dr. Paul Sponseller. So Dr. Sponseller is the Professor and Chief Division of Pediatric Orthopedics at Johns Hopkins Medical Institutions. Thank you so much for joining us. This is his first time attending a family gathering, so we're very thankful and excited to welcome him to the stage.
Thank you, Hope, and it's an honor to be able to talk to you all and to be involved in the care of some of your patients. So we'll talk about involvement of the spine and the neck in FOP, starting with a little joke. Don't worry, I've got your back. Communication in medicine and orthopedics can be very technical and sometimes scary, so it helps to look at visuals, and that's what we have in spades in orthopedics. We have visuals, and you can see what you're working on directly with an x-ray. Sometimes second opinions to hear it from different angles by different people is worthwhile. And always remember that if you have a question, you can ask your physician. So the structure of the spine is that it is made of 25 vertebrae stacked on top of each other. There are 7 cervical, 12 thoracic, 5 lumbar, and then the sacral vertebrae, which are initially several, but they're joined to form one. And these have several functions. They anchor and shape the skeleton, but they also protect the spinal cord, but they also provide controlled mobility by the use of muscles. The flexibility to bend forward, turn around, look behind you, look up, look down. That is the property of all these, with the muscles controlling them and the ligaments and discs supporting them. We all think of our spine as a really stable structure. The word backbone comes to mind. You can say somebody has a lot of spine, which means they have a strong character, and it should be strong and stable. But actually, the spine is not all that stable over time. It has stabilizing forces and destabilizing forces. The stabilizing forces are the ribs, which give the thoracic spine more stiffness than the rest of the spine, like the neck and the lumbar spine move more than the thoracic spine. And the thoracic spine is stabilized by your ribs, which house your lungs. And when that goes wrong, that's where the lung dysfunction, thoracic insufficiency we've heard about come into play. They're also stabilized by muscles, but the muscles to be stabilizing have to be coordinated, and that coordination requires a fully intact neurologic system. And so if you don't have intact neurology from the right and left sides, the pull is unequal and deformity curvature can develop. Destabilizing forces include growth, gravity, and bone weakness or osteoporosis. Growth is probably the biggest one, and Dr. Kaplan talked about how that works. Growth allows us to get about 30 centimeters of increased spinal length from birth until maturity, and so powering yourself up against gravity that much requires a tremendous amount of force, and that has to be balanced by intact muscles and intact ligaments. And if the bones are joined by ossification on one side more than the other, that tremendous force will cause it to twist in a different direction and cause scoliosis. And of course, gravity is also acting on you at the same time, and with just a little bit of tipping point, then the forces become more asymmetrical and cause more and more of a bend. So here's an example of how it can go wrong in FOP. And as the spine deforms, it also rotates. And that causes the ribs to come in more on one side and become wider on the other side, and also to not move as well. So that basically compresses the lungs and causes pulmonary insufficiency or breathing difficulties. How does this growth occur? The growth occurs from the upper and lower sides of each vertebra. Each vertebra adjacent to the disc has a cartilage cap called an end plate, and within that end plate are some growth cells, just like the growth in your arms and your legs, but it's much more fine-tuned and harder to see. So each growth plate grows about 1 millimeter per year. You multiply that by the 27 levels we have, and that's what caused you to grow so much each year. And that growth is pretty slow and steady for the first 10 or 11 years, and then it really takes off quickly in adolescence. So adolescence is the worst time for things to grow. And if there's an imbalance in the growth or the stabilizing forces, a curvature can develop. We quantified that curvature by giving it a number of degrees. We call it the Cobb angle. And just so you know what that is, you basically take a line on the top and bottom of each curve, spanning the curve as widely as possible. And then you take those lines and draw perpendiculars to them, and the angles between those two perpendiculars is the angle of your curvature. So normal curvature would be 0 degrees, but you can have a normal slight curve in your spine, and that can be up to 10 degrees. But as you hear numbers like 50 and 60 and 90, that means that there's a lot of curve and a lot of twist, and that affects your ribs and causes pulmonary problems, the thoracic insufficiency. This tends to worsen much more fast in adolescence. You can see a series of x-rays of the same patient. From age 0 at newborn period, you can see there's no curvature. By age 4, there's a little bit of a twist there. It hardly gets any worse by age 8. And then by age 16, it really takes off because of that growth spurt. It seems to be the rapidity of the growth spurt that really drives scoliosis. So the period of adolescence, the growth spurt, the peak height velocity is when the curves really take off. And so that can really affect the lungs, as you can see here. Basically, on the right side, there's no space for the lung, and the ribs are extremely twisted and bent. On the other side, there is more space. But with FOP, it also may not move as well, except for the diaphragmatic movement. So that's an additional factor that affects your lungs. So spine deformity develops because of an imbalance between the stabilizers, the muscles and ligaments, and the destabilizers, which are growth and gravity. And if it gets to about 25 degrees, the imbalance is so much that it continues to worsen at a much higher rate, more likely to keep going. There are some conservative treatments you can do for scoliosis, but they don't all apply so much to FOP. Seating systems to help provide even seating and decrease that tipping point can be helpful. And it can also include a head support and maybe not using so many pillows. Supportive garments such as a DMO suit can also give you a little bit of external support. Braces are commonly used for scoliosis to guide the growth, especially if it's less than about 20 to 30 degrees. And these are plastic garments that hold you in a straight position. That is not so practical for FOP patients because it makes the breathing more difficult, retains heat, and there's really no data on the use of bracing in FOP. A lot of times it's not really caught until the curve is too big. And with the bone being an issue, it's hard to know whether that's going to do anything. Also, in non-FOP patients, we can put in some temporary rods and use it as internal braces to help stretch out the spine. But there's no experience with that in FOP because we worried that it would cause more ossification and do more damage than it would be helpful. So that really leaves us with the issue of correcting and fusing the spine, called a spinal fusion, as Dr. Kaplan and Dr. Pignolo alluded to earlier. What is a spinal fusion? It's basically straightening and stabilizing the spine in the best position, usually the whole spine in FOP, and then you use rods as well, like rebar, to help hold it straight. But the fusion involves a biological process because the rods would eventually break if they're not supported by bone growth. So we're trying to get bone which is dynamic and regenerative to hold the spine straight permanently. So who is a good candidate for this big surgery? People with unbalanced curves where they just cannot stand up straight and they always feel like they're leaning over, or people who have pain in the area of the curve, or whether it's causing severe deformity of the lung, and especially if they have growth remaining. Here's an example of an FOP patient. You can see she has significant deformity going to the right side and is twisting. You can see how the twist throws the ribs back on the right side, and how that correlates with the underlying x-ray below the clinical photo on each side. And here's another FOP patient who has severe curvature. You can see the large bridge of bone that's functioning like a rope or a tether that causes the spine to grow. And once it gets off center a little bit, that twist just gets worse with growth. And the way we can fix it is to actually go in and separate all those bones, doing what's called osteotomies, and then straightening it over a couple rods. And those rods typically go down the whole spine, and that holds it straight and provides normal curvature. And as the bone grows together, the combination of rod and bone should last forever, and the rods will not break because it's supported by bone, and the bone is held straight by the rods. So that leads to a series of questions you may be thinking. When is it best to have fusion surgery? I think when the curve is more than about 60 to 70 degrees and it still is getting worse, like close to the end of growth, and usually at the end of the growth spurt, around 12 to 13 for girls and 13 to 14 in boys, because as you know, boys mature later than girls. Is it ever too late to do the surgery? Not really, but it becomes more difficult when you get older because your body heals and recovers less, and everything is stiffer and harder to straighten out. How long is the operation and how is it done? It's usually about a 4 to 6 hour operation, and that does not, of course, include any anesthetic difficulties that may arise from jaw stiffness and the need for special intubation. So what you do is you go in and you open up each vertebra by doing an osteotomy between the bones, make it more flexible so it can be stretched out and straightened out. And then you put the rods in and use those to straighten out the spine and untwist it, or what's called derotating it. And then you lock everything together and put bone graft so it becomes one solid and permanent straight piece of bone. After surgery, what's the recovery time and how long is it in the hospital? Let me just preface this by saying this is not something that you really should be looking for, only if it's the last possible solution, because this is a big surgery and it's pretty risky and pretty hard to go through. So this spine surgery is not something you should be doing unless you really have no other options. Typically, the recovery is about a week in the hospital, started with intensive care, and then you can move to a regular hospital room, and then to rehab afterwards to get your strength and endurance back, make sure you're feeding well and your pain is well controlled. Typically, it takes about 1 to 3 months out of school until you're ready to return to school and learn and concentrate again, and your pain is under control. And it takes about 3 to 6 months until you kind of feel normal again. You no longer are focusing or always aware of having had that surgery. We'll see if our patients agree with that. What can happen without the surgery? Well, possibly more pain, more breathing difficulties, and even balances sitting straight may be impossible. What could go wrong with your abilities after the surgery? When you straighten somebody, you alter everything so you make the person taller, and it's harder to reach what they used to be able to reach because everything is taller and straightened out and stretched out. So it's harder to push yourself up, harder to reach things that you need to reach down at your knee level and your ankles and feet. Your personal care may be more difficult, and it's more stiff when you try to roll around. But many people seem to feel like that is a worthwhile trade-off. What complications can happen? The most common one I would say is infection, and in typically syndromic patients, it's about 5%. Fortunately, we haven't had that in any of our FOP patients. But if that does happen, it is treatable, but it has to require surgically cleaning out the infection, giving antibiotics, and then closing everything back up again. We don't want to have that happen. Another possibility is you may need a reoperation if something is twisting above or below, or the rods are getting loose at one end. Pneumonia can happen, and also, of course, damage to the spinal cord is what we want to avoid most of all. We can monitor the spinal cord during surgery with electronic monitoring to make sure that everything is functioning from top to bottom and the feeling is preserved by running signals up and down the axis of the spinal cord during surgery. What are some of the things patients wish they had known before they had this surgery? Just the magnitude of it, I would say, the length of the recovery period, and the adaptations about reaching things and doing your personal care. Complications, especially if they have an infection, are things that typically are surmountable, but take extra time and effort and delay your recovery and return to function. Are any follow-up procedures needed? The statistics on this, not from FOP, because there aren't that many statistics on this condition, but in general, about 5% of patients will need another operation to fix a more minor problem that's going on. Also, we touch briefly on neck issues. Dr. Kaplan mentioned that neck issues can happen in FOP. And that probably, you can see patients who often complain of neck pain or stiff neck, sometimes a twist in the alignment of the head, or inability to look up or look down. And typically, as things stiffen through the joints fusing, if you're looking too much down, you can bend your knees and your hips and look ahead that way. So you see people using their hips and knees to help position their head in space to look forward or look down when they need to. Also, ossification of the sternocleidomastoid, the big muscle here that forms your neckline, can be asymmetrical and could lead you to have a twist in your neck. Or partial fusion of some of the bones can be one of the causes of pain. So we're still learning about those issues in FOP. So in summary, the spine is a very dynamic area, and the imbalance between growth and ossification and the forces involved can cause a twist, which in some cases can really affect the ribs, the lungs, and the breathing, and therefore your health. And so you should support deformities early, try to achieve reasonable growth, and surgery can be used in some severe cases, but it should be the last resort, and not something that most people seem to be needing in FOP. So we'll have time for questions at the end. Thank you.
Thank you, Dr. Sponseller. Feel free to grab a chair, and Dr. Pignolo and Dr. Kaplan, I see you if you want to come on up. And there is a mic still at the front of the room, and then we have Mark roaming, so feel free to use a question stick or come on up to a mic.
Fred, I have a question for you regarding the joints, the ankylosis of the joints, the costochondral, the joints of the rib cage. How penetrant is this phenotype? Are all the joints in the rib cage affected? Is this seen in every patient? Is it kind of stochastic? Some joints have it, some joints don't per patient. What is the penetrance?
You've just hit.
You're good.
Am I okay? Yeah, you just answered the question. It's variable in patients. Some have multiple joints involved. Some have all of those joints involved. Some have none of those joints involved. But most have some. Most have some. And as I said, if it occurs asymmetrically, that alone can lead to scoliosis. And I've seen children who have pretty severe scoliosis before they even form heterotopic ossification, and many of them don't do well. toe. Yes, it's variable, but there are at least 96 joints in the thoracic region that are vulnerable in FOP. And you can imagine that if there is asymmetry in their involvement, how they can be affected. So even patients with classic FOP have variable toe malformations. Some have the classic toe malformation of short bunion-like toes. Others have normal length toes, but they're missing the interphalangeal joint. Others have short toes and a short metatarsal. So there are variabilities, but all patients with classic FOP have abnormalities of the toes, and most patients with classic FOP have some fusion of the costovertebral joints, which may be symmetrical or asymmetrical. Thanks. And this, by the way, this was observed on the cross-sectionally on the CAT scans, on the whole body CT scans that were done in the natural history study.
Hi, thank you for these excellent presentations, and thank you, Dr. Sponseller, for your care of our patients. I can tell you firsthand how grateful our patients have been. So I think my question is, when we're trying to refer patients to you, are there any specific tests that you would like us to order before they come to see you?
No, I think in general, we would like to have pulmonary function tests as a baseline for comparison later and afterwards. But we will order some specific tests if surgery is needed, because surgery is not always the right answer for these people. But we will then order some x-rays with stretching and repositioning, possibly CAT scans, possibly MRIs, and for most efficiency, the surgeon would like to order them so they're done just exactly the way they want. And so we prefer to order them ourselves. But we do want to have pulmonary function tests going on before and after, and probably EKGs or echoes as well.
If we know that FOP affects the lungs and the ribs on all patients, and everybody usually gets scoliosis, why does the bracing not work to prevent as a prevention?
It's a good question. We looked at this in the 1990s. Bracing doesn't work for comfortable reasons. Patients don't want to wear it. It's uncomfortable. It often causes pressure deformities where the pressure soars. And so I refer you to the 1994 article. And we looked at patients who had bracing, and they didn't do well. They didn't like it, and they didn't wear it, and they just didn't work.
Yeah, the way bracing typically works in other patient groups is to straighten you out and hold you there. It's not just locking you in place, it's basically straightening you out and realigning those forces so it can keep it from getting worse. But in FOP, the force it would take to do any straightening is not tolerable. It causes pain against the skin and under the bones, and also restricts further the movement of the chest, and we worry that it might even lead to more stiffening and more ossification by limiting movement. So for all those reasons, it's not helpful because of the practicalities of it.
We have an online question around the pain management and level of discomfort after scoliosis surgery.
Yes, it's a painful surgery, and we try to manage that by using pre-medications before surgery, and then IV and oral medications after surgery, including muscle relaxants, opioids, and non-opioids. And typically, those are needed for about 5 to 6 days after surgery, and then the pain medicine should be hopefully done altogether by about 2 or 3 weeks after surgery. We can see if our patients agree with that, but I think that's about what the time frame is. We try to minimize the use of opioids, but it is a pretty big deal to go through, and with a combination of medicines managed by an anesthesia pain medicine group. They have a push-button thing called a PCA, patient-controlled analgesia, that allows each patient to deliver himself or herself the amount of medicine he needs or she needs when it's necessary. And also cuts it off at a certain point so that they can't take too much opioid or too much medicine and limit their breathing.
I just want to add one thing to that. That's excellent. That we don't like opioids anytime in FOP, not just because of the breathing, which is critically important, but because opioids do stimulate mast cells. And mast cells are very important in, unfortunately important in exacerbating flare-ups of FOP. So.
We did have several questions submitted in advance, and people, stating that their child has scoliosis and wanting to know if surgery is an option for them. And obviously, I think we've heard that's a very individualized decision. But one part of a question that came in that I am interested to hear your insights on is if an individual is participating in a clinical trial, would they still be a candidate for surgery? Do you guys have thoughts or clarification you could share on that?
The answer is yes.
Scoliosis surgery has evolved to a point where we're pretty comfortable offering it to typically developing teenagers almost without too much worry. But in FOP, it's a much bigger deal because of the bleeding and the other complications. So it should not be regarded as something that you are going to have or should kind of bank on having just because you have a little bit of scoliosis. It's only for the most extreme cases.
Yes, and as Dr. Sponsler and I said, it should only be done, if it is done, if the decision is made, it needs to be made very, very carefully on individual patients, and it should only be done after consultation with FOP experts, spinal experts, and it should only be done at centers that have experience in managing the whole team, the whole perioperative team, including anesthesia, preoperative, postoperative care, nursing care, intensive care unit care, et cetera, et cetera, et cetera. So it's a major, major undertaking.
I just wanted to clarify something about clinical trial involvement and undergoing any type of surgery. So I think it's not prohibited, but it definitely requires a lot of discussion with the principal investigator at the site, discussing it with the sponsors, having a kind of an understanding of what medications will be used, because there are drug-drug interactions as well that we have to think about. And so there's a lot of planning that goes into it, whether we should hold the investigational drug for that specific procedure or not, or we can continue it, how best to administer it, and also review kind of the medications that might be administered, whether it's antibiotics, pain medications, that might have drug-drug interaction with those investigational drugs. So it's not prohibited, but it requires a lot of thought process and planning beforehand. Yeah. And if anyone ever requires an emergent surgery, and they don't have access to their physicians, and they're not sure if there's a drug-drug interaction, just hold the investigational drug. Don't hold, life-saving interventions that are absolutely necessary.
And a lot of surgeons are not used to having those cautions and those prohibitions used when surgery is talked about. So remember to bring that up if you're a patient considering surgery. Remember that the surgeon should be in touch with the lead of the investigatory study.
You mentioned an interesting point, Paul, in your discussion that you need normal bone to protect the spinal rods and et cetera. And it's interesting that at least in the animal studies, some of the interventional agents that are now being used in clinical trials inhibit heterotopic bone, but they don't inhibit orthotopic bone. They don't inhibit normal bone formation. So it's quite interesting.
Yeah, I think that'll be something to collect data on, but we haven't seen any adverse effects in fusion in these patients. They all seem to fuse just fine. And if you think about metal in general, it has fatigue tolerance. If you keep wiggling it over and over again, like an axle on your car or a coat hanger, over and over, small amounts of force will cause it to crack. And what that can happen even with big rods in your spine, and we see that happen from time to time. But the fusion prevents that micromotion from happening and protects them over the long term, so the rods and the bone work together like the rebar in a large, tall skyscraper.
I'll ask the, I think, an obvious question, but on the cases that you've done, what heterotopic bone formation has occurred after surgery?
Haven't had any serious problems from heterotopic bone after surgery, but when you're operating, oftentimes you'll encounter large strips of heterotopic bone which are replacing muscle, and that can prevent the normal closure of the wound, so you should anticipate that. And it's not something that you typically have to worry about in the course of surgery, but in FOP you have to worry that taking out that bone leaves a space or void where that bone used to be.
Right. Of the 3 patients who had the surgery, 2 were not on clinical trials, were treated with prednisone before and after, no heterotopic bone, and 1 was on a clinical trial, again, no heterotopic bone.
One more question. I think this one's for you, Dr. Pignolo. You did an incredible job of highlighting the different tests that may be needed to monitor pulmonary function and kind of giving people an idea of when to start those. Do you have any recommendations, or is it just very individualized based on the frequency of when those tests should be performed to monitor change over time?
Sure. So I think one of the more important tests that all 3 of us have talked about is the pulmonary function testing. I think as guideposts, probably 98% or more of individuals with FOP have some type of restrictive lung disease by the age of 15. So that's one guidepost. But yet, younger than that age, I think it could and should be individualized, obviously, if there's progression of scoliosis or if there's some diaphragmatic breathing or some other indication of early thoracic insufficiency, then I think pulmonary function testing should be done earlier than 15. So I think those are some of the guideposts.
Bob, I'm curious, you talked about this pulmonary hypertension developing in some of the patients. I don't know if that reaches the level of pulmonary arterial hypertension or is it anything like it, but there's a drug that's been approved for this, sotatercept, right? This is ACVR2A, I'm sorry, and that works pretty well, although it will induce telangiectasias because it blocks BMP9 as well.
Yeah.
Have you considered the use of this drug for these patients that are developing pulmonary disease?
Winavir, or the trade name of the drug you mentioned, has just been approved, and all the patients that Paul operated on were operated on before that. There is a black box warning on Winavir, like in any of those treatments of severe bleeding.
Yes, there is. Yes,
yeah, there is, and
yes.
so we have not had any FOP patients on that drug, and for that concern.
Yeah, makes sense. Thank you.
Yeah.
Can I ask my question? This is for Dr. Pignolo. I was just wondering, for pulmonary function testing, if you're not able to, if your jaw is locked, how do you do that testing?
So that's a great question. So I think it's much more difficult, and the results probably less reliable. If you have some space between your upper and lower teeth, I think it's probably reasonable to go ahead and do it. I'm more concerned when the ankylosis of the jaw is so small and people have to get nutrition through one side or the other of their mouth, that if they're going to get pulmonary function tests, they're actually breathing through their teeth, and that may not be so accurate. On the other hand, you could argue that you should still do a baseline if they can close their lips around the tube for the test. and see and use that as a baseline for future testing, even though it's probably not as accurate as it could be if there was a free flow of air. Yes. No, they're smaller tubes.
This is for Dr. Kaplan. You mentioned in your presentation that the diaphragm is not affected by FOP. Are there other parts of the body that we should be aware of that are not affected?
Yeah, of skeletal muscles, there have been no reports of the extraocular muscles, the intrinsic muscles of the tongue, and the diaphragm. And after we discovered the FOP gene, maybe it was several months later, I was talking to a young man, young teenager, and I said, you know, you have to do incentive spirometry, and the diaphragm doesn't get involved, so on and so forth. And there's 3 muscle groups that don't get involved. The muscles that move the eyeball, the muscles that move the tongue itself, the intrinsic muscles of the tongue, and the diaphragm. And we don't know why. And he looked at me like I was coming from a different planet. He says, well, of course we know why. He says those muscles never sleep. And it triggered a thought in my mind that those muscles don't, under normal use, become hypoxic. Now, obviously, with pathologic use, they can be, but under normal use, they don't become hypoxic. Think of your diaphragm. It constantly works, and if it doesn't constantly work, we're in trouble. And so we did a study in the laboratory looking at hypoxia, looking at low oxygen tension, and we found that hypoxia dramatically amplifies the signaling that comes from the mutant receptor, and when we decrease that, it can correct that signaling problem. And so those muscles don't become hypoxic. They don't have the amplification of signaling. I'm not saying that's the only reason, but that may be one reason. So the muscles that move the eyeball, the intrinsic muscles of the tongue, and the diaphragm. There haven't been any reports in the medical literature of those 3 muscle groups becoming involved. Now, the extrinsic muscles of the tongue, that's a different story. Those muscles do become involved. They can become hypoxic, and they can cause severe problems and lead to submandibular flare-ups, flare-ups under the jaw itself. So, but the 3 muscle groups I mentioned don't become involved, and we think that may be part of the reason. The lack of those muscles never fatigue. They never get tired. They don't become hypoxic.
The bladder is another big muscle, and that one doesn't seem to get involved either. It's a smooth muscle as well.
Right. And smooth muscles and cardiac muscles, none of the smooth muscles and none of the cardiac muscles get involved with FOP. But among the skeletal muscles, the 3 groups that I mentioned don't become involved.
Christy has a question. Mark, can you get over to her? Thank you.
I think that a big question has been the hype of the surgery. And as a parent, a lot of new families have come to us and asked a ton of questions, and we're always willing to answer them. But I also think it's very important to understand we didn't have a choice. And I think that's a big lesson. Our amazing team came together, created a beautiful plan. It went off beautifully, but it was a very, very tough decision and a very hard surgery. So I just think, you know, there's lots of excitement and it was worth it. But I just think that new families should know that.
Thank you, Christy. That perspective is invaluable. And I also want to thank our panelists. Sometimes reading a scientific publication isn't the most enjoyable thing, but you three have made this session very enjoyable. So thank you so much for the care and the thought you put into making sure this information is accessible to our families and the decisions they make.